So when a patient of ankle arthritis is seen, the patient has limitation in range of motion. Patient will give a previous history of a trauma, or maybe history of idiopathic inflammatory or rheumatoid arthritis, and will point towards the ankle joint. The treatment, on examination, there will be a stiff ankle gait with an ability to dorsiflect actively and passively as well. The patient can given treatment like number one, single rocker shoe, number two, intra-articular injections or braces. Arthroscopic debridement is indicated only if there is mechanical symptoms, or a supraumillar osteotomy with asymmetrical ankle arthritis previously due to talar AVN or osteochondral fractures. The options regarding surgery is arthrodesis or replacement. Arthrodesis is indicated in patients who are young laborers with severe arthritis, previous history of infection or trauma, or AVN of the talus itself. The position is neutral foot dorsiflexion or plantar flexion, that is 90 degree with 5 degree of valgus and some degree of external rotation. The approaches can be either open or arthroscopic. In open approach, you can do a lateral or anterior approach, excise the fibula, remove the cartilage, and put a bone graft, and screws can be placed from superior to inferior, or you can do anterior plate. A Blair type of fusion is indicated in the talar neck fractures, in which a plate is placed with a bone graft peg going to distally towards the talus itself. Arthroscopic ankle fusion is advisable in those patients with soft tissue envelope is not optimal. The union is about in 12 weeks. Union is achieved and non-union is 7%. Other way around would be to place a fusion nail. The problems which can happen is wound breakdown, delayed union, infection, malalignment, and ankle osteoarthritis. Regarding the ankle replacement, these are indication for low demand individuals. The BMI should be optimally controlled. This can be indicated for post-traumatic arthritis as well as rheumatoid arthritis and osteoarthritis. There are some contraindications for these ankle replacement. Number one is coronal malalignment of more than 15 degrees, history of septic hip knee joint, ankle joint, AVN of the talus, neuropathic Charcot foot, or unreconstructible ankle joint. Subtalar arthritis, a fusion can be achieved in subtalar joint before going on for ankle replacement surgery. Regarding the generation of ankle, the first generation is highly constrained cemented implant with incongruent poly and has an early loosening rate. The second generation implant is an agility implant, which is all polyethylene tibia. And these are porous coated component with fixed bearing surfaces and poor long-term results. The third generation is a mobile bearing knee. It's called Scandinavian Total Ankle Replacement Star or Infinity in UK. It is a tibial and talar component which is cobalt chrome. The talar component has a ridge for guiding polyethylene. The poly is ultra high molecular weight polyethylene, and there are two anchor bars to improve tibial fixation. Regarding the survival rate of the ankle fusion, a star versus ankle fusion was a study conducted in 2009, which shows a fusion revision rate of 8% in 8 years, with complications of wound problems, infection, periprosthetic infection, subsidence, and aseptic loosening. Regarding a TARVA trial, which was a total ankle replacement versus fusion trial, which was done with two prospective trial groups, and outcomes were assessed by Manchester Oxford Foot Questionnaire at 52 weeks interval. The outcome was assessed and which showed this study was basically done on 280 patients with age of 50 to 85 years of age. Both did improve the quality of improved pain and quality of life, but there was no significant difference between the two groups. The total ankle replacement did better than fusion in patients with arthritis of surrounding joints. That way, it was indicated that the health of the surrounding joint is important, and ankle fusion does have more episodes of thromboembolic events. The Tarver trial also showed thromboembolic events are more common in ankle fusion, while the nerve injury is more common in ankle replacement. Moreover, wound problems are more common in ankle replacement than fusion.